Thank you so much. Um, Firstly, I did tell the team here that it took me 36 hours to get here, but I'm not jet lagged. I arrived last week, so hopefully this will be short and sweet. And this was fit into my schedule. As they say, we all get delegated by somebody, and my boss had delegated this into my schedule and said, "Oh, you're presenting at this conference." I said, "Oh, wonderful. Thank you for the prod." So I'm going to talk about a really fantastic initiative that we're doing at the moment. It's a culmination of 3 years of working with multiple standards bodies around the world, lots of healthcare practitioners involved in this piece of work, and WHO, as well as some partners like CAHO and ISQA that were involved in this piece of work. So I'll take you through the program. A little bit of housekeeping, as you do. I have to tell you a little bit about BSI first before I can go into the exciting stuff that you might want to hear about. In terms of BSI, most of you might know British Standards. We're over 120 years old, so we're an old soul, but hopefully a wise soul. We've been around for many, many years, and our purpose is led by a royal charter, which is driving impact for a fairer and more sustainable society. So we try and involve ourselves in projects and programs where we feel we can make a difference. But also the benefit of British Standards is because we're a non-for-profit, we take all the profit that we do make. So we then invest it on impact projects with partners and opportunities that we feel that they can make a real difference. So that's a little bit about the organization and how it's set up. The only reason I put this slide up is quite often people kind of go, British Standards, that was started as an engineering company, and so how does that relate to healthcare? So that was where we started. It has evolved, the organization, and we do a lot of stuff in healthcare. In fact, we have over 10,000 healthcare clients, and those clients operate across 193 countries. So we are global. We do a lot of work in healthcare service delivery. So we do a lot of work with healthcare organizations like medical device companies and medtech. But out of those 10,000 customers, over 4,000 are involved in healthcare service delivery. So hospitals, aged care, residential disability services. So we are a very broad church in terms of what we do in healthcare. In healthcare, our focus has predominantly been around delivering of quality and patient safety. So anything that to do with those two components, we've focused on around what we can standardize, how we can help support, drive some improvements in these areas, and what does that look like. BSI itself, obviously, has got a heritage in healthcare, which a lot of healthcare organizations here might know about. Some common standards, which the tech industry calls them the Big Four, but BSI started a lot of these standards actually were originally BS standards that then got converted into international standards. So you might know about 9001, you might know about 14001, and you might know about 27001, which are all very big standards globally. They all started with British Standards originally, and then they got converted into ISO standards. So we do a lot of work in that space. We also do a lot of complicated stuff like that. So there's a lot of stuff happening in a healthcare setting or a hospital setting that we sometimes don't think about standards, and they just kind of automatically happen. But underneath it all has always been a standard that has brought that framework together or that service component together. So as part of this journey, we've been involved in healthcare for, as I said, very, very long time, and we are across multiple service delivery elements, as that slide shows. Now, that's the housekeeping done. So let's get into the exciting bit. So ISO 7101 is a culmination of 3 years program that BSI started with some partners as well as some healthcare professionals that came to BSI and said, we don't actually have a framework that is specific to healthcare and quality management, but also something that we can understand. Yes, there is ISO 9001, but actually that is not designed for a service industry or for healthcare practices, and there are a lot of components within that framework that don't really quite fit. So when we talk about patient safety, or when we talk about medication management, or we talk about hazardous waste disposal, when we talk about how we deliver patient-centered care, not quite sure where that fits in really effectively and what part of the standard that fits in. So can we design something that is designed by healthcare professionals for healthcare professionals? And that started a journey just over 3 years ago, and then the pandemic hit. So it all had to be done virtually. So a little bit about the standard itself. So it was designed with experts, healthcare experts. So these are clinicians, registered nurses, clinical hospital directors, aged care delivery, allied health delivery support people, as well as doctors. So across 24 countries, United Nations Sustainability Development Council was part of this program. WHO had their technical team involved in this program. And then obviously 40 national standards bodies. So these are bodies that represent national interests at, across multiple countries. The catalyst, obviously, as I said, was designing something for the healthcare sector by the healthcare sector. And it was defining, how can we help organizations, regardless of size, service type, or complexity, deliver in a systematic way using an underlying quality management system that is fit for purpose. The other side benefit was obviously in a lot of markets that we operate in, there's underlying regulation. So you have, in England, you have the CQC. In other parts of the world, in Australia, New Zealand, you have, Health Cert, and in Australia we have the, Australian Healthcare Quality Commission, as well as the Aged Care Commission. So there are underlying regulations that these organizations have to deal with already. So it's about how do we help them not have another thing added on, but actually have a system that helps them achieve all of these requirements whilst they're delivering services in a very systematic way. So, the gist of the components of the standard that are different or unique to healthcare. There is a culture around quality, which is across most standards, but it really thinks about patient-centered care, co-production, dignity, and equity of healthcare. So, thinking about those components, there is criteria within the standard that define some of these parameters, and you really need to think about as an organization how you do this, and what's an effective way of delivering that. It focuses on workforce wellness as well as patient safety, so those things are very well defined within the framework. There was an important element that was raised by a lot of the clinicians that we need to think about clinical risk and non-clinical risk, and those are sometimes managed at two different parts of the organization. So how does this how's the standard going to address that, and how do we capture that? So it addresses that. And then obviously, like most good quality management system frameworks, it focuses on continuous improvement and the continuous improvement process. So what we thought is, it's fantastic getting together with a lot of healthcare providers, WHO and UN, and creating a standard, which is great. How can we now showcase that the standard actually works and actually brings some value to the table, and how do we share that? So one of the things that we kind of did, I'm going to skip past the slide because this is just touching on what Martin already touched on, which is there's a lot of healthcare things that we're trying to with workforce shortages, patient safety, technology integration, rising costs, data security. It addresses a lot of these things, but we already know about these things and they've probably been done to death. So the journey. So we kind of said, okay, well, how do we test whether the standard works in different healthcare settings, but also across different geographies which might have very different healthcare systems? Don't ask me why. The two places that we chose, the first place we chose was obviously, United Kingdom, because we're a British standard, so it kind of makes sense to be doing it in this market. The second market we chose was India, because it's unique in the sense that most of the healthcare delivered is in private. Most of the healthcare that is delivered is non-regulated. There's, you need to have a medical doctor qualification, but beyond that, there isn't any such oversight or regulation that, monitors how things are performed in that market. And then we thought, okay, do we have partner organizations that we can partner with? And our criteria was two things. The journey of implementing this is going to take 18 months, so we need commitment from the organization for that 18-month period. There are costs involved with the implementation, which is technical expertise, assessment of the organization's framework, developing processes, implementing systems, training people, understanding how the framework's going to work. We will pick up that cost. So we've said we will take that cost burden away and then help the organization implement the system, the framework, do the whole journey with them over the 18-month window. The only thing we needed from them, obviously, is their commitment for that 18 months, the ability to capture data, although it will be anonymized, and we're not necessarily going to, publicly share who the organizations are unless they have interest in, participating in that process. But the idea was we'll take data anonymized so we can then showcase that actually there are some benefits we can deliver and there are some improvements that you'll see as a result of this. The types of services, obviously hospitals, ambulatory, radiology, fertility, NHS trusts. Now, to be confidential. That be confidential. That's not to be confirmed. It's that be confidential because we can't share the details of any of those organizations. So they're all confidential, but as the case studies will be published, we will start to work with those organizations to showcase what we're doing and how the benefits have been, observed or showcase if they have been benefit observed, because it's both ways, right? We don't want to just help people implement something if it's actually going to deliver no observable benefit or value to their organization. We then sat down with those organizations as well as WHO and the team at BSI to see how we can measure metrics and what metrics are relevant to measure and how do we do that well. So in terms of the metrics that we captured, reduction in patient wait lists is something that everyone was interested in. Uplift in service user experience, so that's around patients feeling empowered to be in that service in terms of the journey through the service, but also from I'm involved in designing my care and what does that look like for me, and am I happy that that was done at a level that is of interest to me. There's the improvement with retention as well as engagement. So obviously there is components around employee satisfaction, which relate to training, education, opportunities. They also relate to workload, work and life balance and things like that. So that was quite important for organizations to see some improvement metrics in those areas. And so we've defined some targets specifically under there. Side bonus, people wanted to see if they could improve their compliance to their regulated standards. So where they have regulated standards, particularly in this market, they wanted to see that that was actually going to help them improve their regulatory compliance without adding an additional burden to their organization. And then obviously the last thing is reduction in readmission rates. This was not so much something that a lot of organizations in the NHS wanted to necessarily track because they didn't necessarily see a huge issue in this space, but it was quite important to WHO as well as the India organizations because they have quite a large throughput, so sometimes they're going through the volume quite quickly and therefore they wanted to see what the rates of readmission were. So we've defined those parameters and we're tracking those parameters across those organizations. What does the journey look like? So just in terms of context, what we've done with those organizations, we've defined key gates and what happens at each gate. So initially, we're doing the planning, which is activity with, engaging with the organization, talking through the roadmap of activity that's going to happen, define, what technical expertise are going to be required because there are different types of services that are involved in this process. Provide some training across the standard, provide some insights about the internal audit mechanism so they can then capture those, track and monitor those benefits or track and monitor the reporting requirements, and agree on scope. So in a lot of the organizations, we're not trying to do this across the entire organization. We have picked up specific components of the organization where we're doing this first with the benefits then being observed that could be deployed across the greater organization. So, we understand the challenge of if you're operating a large-scale organization that might be multidisciplinary, it is not that easy to just kind of blanket deploy a management system. So the idea was we'll do this systematically. The second phase, obviously, once that's all been agreed, the scope's been agreed, and we've agreed the kickoffs, we then have training and deployment. So obviously we commence engaging with the technical experts who come into the organizations. They do an initial gap analysis of where the organization is baseline, what gaps there are between where the standard needs them to do some improvements or changes versus where they are already performing and the standard aligns well. That gap analysis is also done with their regulated framework. So if they have in the NHS England part, if they have a CQC requirement, we have mapped the standard across the CQC requirements, and it maps how that organization is performing across those requirements, as well as provide some insights as to where the gaps are or where the CQC standard might be better or have a better requirement identified. So whatever the highest level is, that's the level we've gone with. And then obviously we've baselined the data at that point. So once we've done that gap analysis, we all agree on the baseline metrics and we start tracking those baseline metrics before we commence implementation, because we want to see how the organization is performing at the starting point, so we have some data that we can track over that 18-month period. Obviously, then we begin the implementation piece, which is the changing of the quality management system if it's required, implementation of processes based on the gaps that we've identified, training of staff or upskilling of people in certain parts of the organization that might be identified, gaps or key issues or areas that might have been picked up through the gap analysis process. We also, at that point, do a second baseline. So this is basically, month 8 to month 12 window. We then take the second baseline data to see how the implementation has gone to that point, but also how the organizational metrics, baseline metrics, are tracking. I'll show you a next slide, which we've seen some improvements because India, the program has been almost 9 months in. NHS is only nearly just under 3 months in. There are some good improvements, but as I said to someone, it's always great to get improvements at the start because eyeballs are watching and everyone knows what's happening. So the metrics naturally start to improve initially. So it's, early days, we're seeing some good improvements, but we're not, counting our chickens yet. So that's where we're at with that process. And then obviously the tail end of it is the review and finalization. So I guess we'll have 4 gates of data that we capture across those metrics that have been identified. Now, those metrics that I showed before are not the only metrics we're tracking because the organization can choose some other metrics that might be of interest to them, specifically to their performance, specific to their service delivery type. But the idea is we're tracking those over that entire 18-month window to see the progress and improvements that are being tracked and measured. One thing I actually did fail to mention earlier, sorry. This also helps consolidate their continuous improvement or their quality improvement programs, because what we also found through this journey, which we have done with the NHS organizations, is each area of the business was doing something different and using a different framework to manage their quality improvement program, which was causing an additional burden of resource but also tracking. So if you were able to consolidate that into this framework, we've done that where that was possible to minimize resource overlap or double up of activity. So sorry, I just completely forgot to mention that point earlier. So finally, when we come to the end point, the idea is, we review those metrics after that 18-month window. We then, work together on doing a collaborative assessment of whether there was value, whether there was benefit, how the metrics have moved or improved or not improved, why that's the case, and that will all be published essentially in case studies, so that we can then share with them with organizations and say, look, this is the value of doing this is what we learned, these are the outcomes, these are the types of services we went across, and showcase that across the markets that we operate in. So that's where we're at with that process. Just wanted to quickly show this slide. So this is the type of stuff. So even though we have the high level metrics, this is one of the organizations in India that's doing this, which is a 500-bed small hospital. They call it multidisciplinary in India. And these are the metrics that were of interest to them. Now, we haven't tracked waitlist time because a lot of the care, as I said, is private care delivered in India, and they don't have waitlists. So essentially, when you want to walk into a service, you just walk into a service and they start to triage you, and you go straight through that service at that point in time. So they don't actually have waitlist times. But they do have, discharge times, and they're very keen to see how things are improving or not improving. As you can see in the first one, there's a slight increase in time. So, that metric isn't looking good, but certainly there are some other metrics that they're tracking to see how things are going across the organization and where they're seeing benefits or no benefits at this early stage. So it's just kind of to showcase that, some things are important to some organizations, some different metrics are important to other organizations. We've given the organizations the opportunity to define what they want to track. And then we had this thing happen as we were starting for the NHS. So the good thing was I was at the NHS Conferex and listening to Amanda talk about some of the priorities that have come into the NHS. And it was quite nice to kind of see this because the organizations in the NHS were already organized and started to operate within partnership. A lot of the things that were highlighted in here, actually, we were already doing with those organizations and with those frameworks. So things like, focus on overall quality and safety of the service, focus on design and delivery of the improvement programs, co-production, all those kind of fantastic things that we sort of talk about were already in this report as well. So it kind of aligned well in terms of what we were already doing with those organizations. So we didn't have to re-engineer too much, but we have taken this into account into the program just to make sure that we're in alignment. That is me. I've just chucked our healthcare service email in there, so if you wanted to know more about the case studies, because I was conscious of time and not knowing how much time I would have had before I arrived here today. So I did put an email in there because it's important for us to kind of get feedback from you guys as to if there's any issues that you feel that might be with the approach that we've taken, or if there's more you want to learn about, what we're doing and how we're doing it and what the data looks like. So anyone wants to reach out, please do reach out, and we'll happy to share what we're doing. Thank you for your time.